breathlessness, it is one of the distressing symptoms we usually see here. Because most of the time, if a patient comes with pain, we give analgesics and the pain settles. Sometimes the patient will smile. But that is not in the case of breathlessness. We can only reduce it. We cannot completely take away the symptom. It also causes psychosocial distress for the patient and for the family because continuously they are seeing someone gasping for air. That is a different story. So, mostly it will be a very distressing symptom for patient and family. For us also, as medical professionals, we also find it a bit difficult to manage the situation because most of the time all the underlying causes of breathlessness will be progressive, mostly patients coming with cancer, other diseases like heart failure. Most of the time all the diseases will be progressing. So once we start giving treatment, sometimes it reduces. Later, as the disease progresses, we have to keep on changing the medication. So in that way, it is distress and it is very difficult for us also. But we'll manage it. Okay. So about breathlessness, next slide. About the prevalence, mostly we see lung cancer patients coming with breathlessness. But not only that, we see a lot of diseases causing breathlessness, like heart diseases, heart failures causing pulmonary edema, which comes out as breathlessness, then renal failure, liver failure, patients with ascites. All of them will be having this kind of difficulties. So it should not be concentrated only to the cancers associated with lungs, but it is seen in a wide range of diseases. Next. So, the American Thoracic Society defines breathlessness as a subjective experience. It means each patient will say it as a different experience. For everyone, it will be different. For some patients, next slide. Some patients, they describe it as air hunger. Some will tell that there is a lot of effort. And some, they describe their difficulty as a tightness. Next slide. So some people, they will literally tell this as, doctor, my breath is not satisfying me. I'm starving for air. Literally, we have heard so many patients. Mostly, we have CA lung patients here. And most of the time, these will be the words said by them. And it is a very disheartening situation. Next. And some will be describing as it's an uncomfortable sense of respiratory work and effort. And patients will be describing it as an effort to breathe. There is an effort to breathe. I have to give a lot of effort to get one gasp of air. And my breathing is requiring more work. And some even describe it as tightness, as a chest tightness. It could be because of a pathology like underlying pathology like bronchoconstriction. So a patient with, I'm trying to say that a patient with breathlessness may describe their experience as different things. Could be work or effort, as an air hunger, or it could be tiredness. So you have to ask what it is. Okay, next. Now coming to the primary causes and the usual causes we come across here. Mostly it will be CA lung or any other malignancies causing a metastasis to the lung. This is the most common cause. Okay. Other causes are lymphatic infiltration by the tumor. The tumor itself can block all the lymphatic vessels and there can be a lymphatic infiltration of the vessel and the patient can have a breathing difficulty. Or it could be a malignant pleural effusion. Malignant pleural effusion means the patient will be having a severe kind of pleural effusion, massive pleural effusion. Otherwise, it could be a tracheobronchial obstruction. All these are the causes. I'm telling all these are the causes of breathlessness we usually see. So, tracheobronchial obstruction is also very common because most of the time most of the tumors at the advanced stage, it will be like very big in size. And all these things will be causing an obstruction, sometimes even small bronchus or sometimes a major airways. This will cause a great distress for the patient. It will not respond to any medications. So that is also a very common cause. The next one is treatment. Sometimes patients undergoing surgery or post chemotherapy or post radiation, these people will be having fibrosis after a long time, after chemo, after radiation and all. Some people develop fibrosis and the lung will not be able to expand like in normal ways. Even that time also, the patient will be having dyspnea or breathing discomfort. So these are the common things we come across. Next slide. Other causes are also there, as I have already mentioned. Other cardiac disease, not only cancer, but other cardiac conditions like cardiac failure, angina, arrhythmia, myocardial infarction. All these ends up in a fluid accumulation in the lung and it causes breathing difficulty. Pulmonary diseases like infections, pneumonia, other infections, patient having COPD, pneumothorax, pleural effusion, pulmonary embolism. I'm telling all these things to just keep it in mind. Not just don't focus on cancer. You have to think about all the situations also. We can help patients having breathing difficulty in all these cases also. Once, if it is not responding to usual treatment, we can give palliative care, palliative treatment for these patients also. Next slide. So, in cancer also, a patient having cancer, it is not only the cancer that will cause this difficulty. It could be also because of ascites. For example, a patient having liver disease like CLD or cirrhosis, those patients will be having ascites also. Ascites means they will have fluid accumulation in their abdomen. After a long time, if the patient is not eligible for tapping, tapping of fluid, this fluid will accumulate in their abdomen. It in turn pushes the diaphragm from below. This will also cause breathing difficulty. So, do not focus only on pathologies related to lung. You have to always look for all these symptoms also. Next one is cachexia. Cachexia means the patient is losing weight because of cancer. Oral intake has reduced. Patient is not taking any food. All his muscles will be wasted and everything goes thin. And the patient will have respiratory muscle weakness. We all know that respiratory muscles also help in respiration. So when this muscle get weakened, it will again be a burden for the lung to expand and contract. That in turn causes a discomfort. Next one is cancer microemboli in the lung. Sometimes a patient having cancer develop a lot of embolies. This can cause a pulmonary embolism. That in turn can cause a difficulty. Next is pleural effusion. This is very common. It could not be because of the malignancy there. The pleura will be affected and a lot of pleural fluid will be secreted. And the patient will be having pleural effusion. In that case also, patient will be having breathing discomfort. Next slide. Next one. This is a very important cause. Anxiety, panic attacks, depression. A patient who is having breathlessness, they'll be always anxious. And we have a cycle. I'll show you a cycle. Next slide. Just focus on this slide because this is very important. Most of the time, patients coming here to our OP with breathlessness After we settle them for some time, our patient will be having relief. We'll ask them, how did you feel when you had this breathlessness? And I would say 90% of them will be telling that, doctor, I thought that I would have died that time. They will tell that I thought I'm going to die. My death was near. So when a patient gasps for air like this, they will definitely think of death only. That increases the anxiety. That in turn increases the urge of breathing. So this point should not be forgotten because as the healthcare professional, as a palliative care nurse or doctor, you have to tackle this. You have to address this. It brings a lot of difference. I'll tell you about in detail after some time, but don't forget about this point that the patient will be, they'll have a great fear thinking about a death when they have breathlessness. We have to reassure it. I'll come to that later. So this cycle is very important and this cause is also very important. The anxiety caused due to breathlessness increases the intensity and severity of breathlessness. It should be tackled. Next slide. Now, as a nurse and as a doctor, now we have discussed about the causes, what could all causes could have caused breathlessness, all those things to look for to come into mind. We have discussed all those things. Now we are starting a job. We are going to assess the patient. We are going to take a detailed history of the patient, like how did they have this disease, initially what happened. We have to take it detailed. Okay. Now coming to physical examination. Next slide. Sorry. About what and all. Next slide. About the history taking, these are the things we have. We should not forget about the onset. When did it begin? What is the duration? How frequently does it occur? What are the palliating factors? What makes it worse? When does its breathlessness increases? When does it reduce? How are you trying to cope? What is the quality? Is it like air hunger? Is it like a breathing effort? Is it a tightness? What other related symptoms? Mostly it will be associated with cough. Most of the time, patient will be having chronic cough. The disease and all must have started with cough. So most of the patient with breathlessness will complain about cough also. So do not forget to ask about other symptoms also. Then, like the pain score, as you all know, for pain we ask severity in a scale of 10. Like if it is 0, it is a very mild symptom, and if it is 10, it's a unbearable type of symptom. So we'll assess that. And most of the time, these patients will be taking some medications even before we are starting palliative care treatment. So we have to ask about the treatment, but that because this is important because we should not continue the same treatment for them. The patient is not benefiting from the treatment. So what treatment the patient was taking is very important. So we have to ask all about all these things before examining the patient. These should be included in the history along with the previous past history of the patient, like where they have taken treatment, what they have done and what is their plan and where did they go. They must have consulted many hospitals for this breathlessness, like COPD patients. For example, I'm telling, they'll consult different hospitals because their symptom will not, those patients, those who are not knowing about this. I'm telling about those patients who are knowing about it. So they'll be consulting keep on consulting different doctors because their symptom is their difficulty is not reducing. So they'll keep on searching new doctors, new centers for their relief. So that is also very important. Okay, next. So now coming to the physical examination. So you're seeing the patient in OP, and mostly the patient. This I'm showing this picture to explain the position of the patient. Mostly the patient will be lying like this, nearly 45 to 60 degree. So this look itself shows that patient is in discomfort. He's not able to lie down. Most of the patients will be like that. They won't be able to lie down like in a supine position, straight, flat on a bed, because it will increases the breathlessness. So the first look of the patient will even tell you that what and all difficulties they'll be facing for a long time. Some people even say that I have not slept for many days. I'm sleeping after like sitting in a chair and sleeping since a very long time. So you have to take a shot of the first look of the patient, that whether he's lying down or whether he's sitting or whatever. So that is the first thing. Next slide. Okay. So patient has come to OP. You have checked his position and all. Now we are going to start taking the vitals. All the vitals are being recorded: BP, pulse rate, temperature, respiration. Everything is important. Next slide. Respiratory rate in this case is very important, because sometimes it could be 36, sometimes it could be 28, sometimes it could be normal. Like the patient will be having a normal rate, but the patient will be having difficulty in taking air. Like we said, the work of breathing or breathing effort, that will be his problem, not the respiratory rate problem. So this is also important. Keep this in mind. So respiratory rate, we have to count it for 60 seconds. That is very important. We have to look at the chest rise and fall, and we have to record the respiratory rate. Next one. The next thing, saturation and pulse oximeter, which shows the SpO2 of the patient. Okay, let me tell you one thing. In a usual setting, in a casualty, when a patient is brought with breathlessness, everybody will be running about, everybody will be checking the vitals, and one person comes with the pulse oximeter. He connects the oximeter and sees that the patient is desaturating. Suddenly, there will be a rush. Somebody will be coming for oxygen, and some people coming for intubation, ventilation, and all the rest of the procedures will be associated, will be concerned with the pulse oximeter. But here, in palliative care, a patient with advanced malignancy and in a situation that nothing can be done for him, there is no amenable treatment for him, there is no definitive treatment. A pulse oximeter is not our driving factor. Okay, we'll check the SpO2. We see that it's 86, or let it be 80, 76, whatever. The nurses and the doctors, if we are
Oxygen
using
is
it,
given.
the problem, I'll tell you the
Oxygen is
problem.
given, ma'am.
Sorry?
Oxygen is given.
Okay. After checking the, okay, I understood. After checking the SpO2, you give oxygen, right? That is a usual scenario. I am trying to describe a scenario in our setting. A patient, I'm telling a patient with the advanced malignancy. Is the what his lung is fully filled with mass or malignancy or tumor, and there is no point in giving oxygen, because oxygen cannot be utilized in such a situation. In such situation, this pulse oximeter is not going to help. Okay, like you said, we give oxygen, and sometimes the saturation level may increase from 80 to 85 percentage. But my patient is not improving. His discomfort is not improving. Is there any use of giving this oxygen?
We have to start paracentesis, something to drain out the fluids by ultrasound guided.
Yeah, that is next.
As a help of palliative treatment to keep the patient comfortable if they willing.
Yeah, that we'll be discussing. First, I'm telling that we are assessing the patient, and when it comes to checking the saturation, certain things we have to keep it in mind. The rest of the
Positioning. First thing is positioning, no?
yeah, positioning the patient. We can. That's what I said. We can keep the patient in like Fowler's
90
position.
degrees. Yeah.
Not
Fowler's
mostly
positions.
Fowler's position. It could be 45 to
Paulus
60.
position.
Yeah.
Yeah.
We can keep the patient. That is the picture I have shown in that physical examination. That's what I was trying to explain. Okay. We have come back after that. We are checking the pulse of saturation of the patient. I'm telling in the palliative care setting, patient having advanced malignancy, there is no point in keep on checking the saturation. I'll tell you why. Because, like I said, you have checked the saturation of the patient, and it is showing like 80 percentage, and you started giving oxygen, and the saturation has increased to 86 percentage, but the patient is not improving. So that is a question. But everybody will be keep on. Everybody will be looking at the pulse oximeter. Doctor comes, nurses come. The patient will be forgotten there. That is why in palliative care, what usually we suggest is we have to check the saturation. Okay. But repeated need of checking the saturation is not advised. If it is helping the patient, if we give oxygen, and if it is helping the patient, that is a different scenario. I'm talking about a condition when the oxygen is not supporting the patient. So just keep this thing in mind, saturation and pulse oximeter. You have to check it, but there is no need to repeatedly check the saturation of the patient. If the patient is having an advanced malignancy, there is no need. That's what I'm telling. You can do. There is nothing like do not check. I'm not telling like that. But it is not helping. Okay, next. Now look for another like other uh, conditions like cyanosis. Most of the patients will be having central cyanosis due to oxygen deficiency, hypoxemia. We have to record all these things. We have to always look for these things. Next slide. Now coming to general physical examination. In this one, we see for the position of the patient, like I told, like active accessory muscles, those patients who are having cachexia. I'll show the picture next in the next slide. So first one is positioning of the patient. Position of the patient. Look at the position. Next is active accessory muscles. Patient might be having like a weak or wasting of accessory muscles, which could increase the breathlessness. Patients having a long-term breathlessness may have a nasal flaring. Most of the people will be having mouth breathing. And just show the pictures. Next slide. This is cancer cachexia. And you can see the wasting of accessory respiratory muscles, intercostal muscles. This is very common in cancer. Okay, next. This is a nasal flaring of the normal nostril. Just look at the normal nostril and flare nostril. All these are our findings. We have to look at the patient and we see that, yeah, that he is suffering. What that tells you is he is suffering since a very long time. Okay, all these things we have to look. Next. Sure. Okay, previous slide. Previous slide. Previous slide. Okay. So on inspection, we look for all these signs. Palpation, percussion, the usual things uh, will be done. Auscultating the patient for any wrong eye, or if the patient is having any wheezing, which could alter the treatment. Which also conveys you that it could be because of the bronchoconstriction. So all these things you have to notice. So we have started assessing the patient. We checked his vitals. We checked all the four vitals, including the saturation. Next, we came to physical examination. We checked for all the signs, physical signs, like the positioning. all those things. We auscultated. We tried to find like any decreased. In auscultation, we see many things. It will be like very lengthy if I tell all those things. So just you auscultate the patient, look for any lesions or onchi like that. Next slide. Okay. Now, coming to the management of this patient. So, after assessing the patient, just you are looking for all the signs, you're seeing everything. Now, what comes to your mind? The usual scenario in a casualty. You might be sending the patient for different investigations. A patient with breathlessness or pneumonia, seeing a patient with pneumonia, you will directly send him for X-ray, or you might tell you have to do a USG. We have certain doubts, but here, if you know that the patient is having a disease which has no cure and which has advanced, we have to think twice before advising a investigation like a X-ray. We are going to advise a investigation only if it is going to alter the line of management. That is very important. There is nothing like don't do any investigations for patients who are having palliative care or who are having advanced malignancy. It's not like that. You can do, but only if you think that there is something we have to decide whether this treatment is to be done or that, like a pleural effusion. Sometimes if a patient is having a pleural effusion and you want to check that where up to what level the patient is having an effusion, like how much is he having an effusion, is it a mild or it is a severe kind, and that we can alter the treatment. For example, we can do a tapping for that patient. So in that case, it is helpful. Okay. But a patient coming to your OP, coming to palliative care setting with advanced malignancy, he's having severe breathlessness. Will you advise him an X-ray? Is it going to help him? If it is going to help him, definitely you can do. But if it is not going to help, should we investigate him? Should we send him for CT again? You have to do a HRCT. Please go and do this and come. Should we say that to them? No.
No.
Yeah. That is important. You should always think twice. So investigations are only done if it is going to line or like alter the line of management. Okay. Next slide. Now we are going to start the treatment. We have assessed the patient. We have decided that this patient doesn't require this one scenario. In this case, like he's not requiring. No, there is no need for any investigations. We'll proceed with the patient. So we are going to start our treatment. So as a nurse or as a doctor, you should keep all these things in the mind. You are dealing with a human being. You are going to see that patient. The patient is in breathlessness. You checked all the vitals. You checked all the thing. You palpated him. You auscultated him. Everything you have done. Now, just look at the patient. He is having breathlessness. Did you notice him? He is in suffering. He is panicked. He is thinking that he is going to die. He is not able to look at you. He is not able to speak. Just look at him. Speak to him. See him. See him as a human. He is in suffering. He is scared and stiff. Reassure him. Talk to him. Tell him. We understood that you are having severe breathlessness. We are there to care for you. Calm down. This word goes to his brain. He may not be responding. That's what I said earlier. The anxiety. The anxiety of the patient increases his effort. But when you try to reassure the patient, their anxiety level comes down at least to like a small level. That decreases their urge of breathing. Even without giving any medicines, they'll calm down. Not like fully like I am okay, but it helps. So don't forget to give a reassurance. Just start treating. Okay, the first thing you have to do is this one: reassure the patient. Don't give a false hope and all. Don't tell like I'm going to take care of you and you are going to be okay. Don't tell like that, because the patient himself will be knowing that he's having like a big disease and nothing is going to happen and there is no cure for this disease. So don't give false hopes. Give achievable hopes. Give realistic hopes. The best thing what we do here in our OP, what we usually tell to our patient is, one of us is going to be there with you until your symptoms becomes less. Be with them. I know you are a busy sister, busy doctor. You can't stay with him for a long time. That's what we told. One of us could be a doctor, could be a sister. Somebody be with him, at least for some time. That will bring a great reassurance for him. Now, ask him for any wishes. Do you have anything to say? Sometimes some patients will sit tell their doctor, I want to go there. I want to be at my home. Why did they take me here? I don't want to continue here. I want to be at my home. Just talk with the patient. Just know the patient. Okay. So now we have reassured him, and now we are going to discuss with the family. Family is very important. The caregiver, the one who has come with him, who is equally affected by this patient, by this person. They'll be in distress. They'll be panic. They'll be anxious. Reassure them also. Talk with them. Talk with them regarding the problems. Talk with them regarding the condition of the patient. He's undergoing such and such situation. It could be because of this. And explain what we are going to do. That is very important. Because in a palliative care setting, the things are little different. It's not like we regularly see in a hospital setting. So, after starting the treatment, they'll notice that this is not the usual things that is practiced in other hospitals. We should not have come here. They should not think like that. So, before starting your treatment, you should tell them what we are going to do. We are going to look at the patient, not only his difficulty, his emotional, his spiritual, everything we are going to address. So, also, we are not going to treat the patient. We are not going to give any chemo. We are not going to give any radiation. We are going to see the patient. We are going to try to settle the patient. So, this is very important before starting the treatment. Have a conversation with the family. That is a must. Okay, next. Now, do not forget to correct the correctable measures. Sometimes this breathlessness could be a cause that can be correctable. That should not be forgotten. Patients coming to palliative care, they just need only, it's not like they need only palliative care. We have to think the wiser side of it also. Is the problem because of the lung cancer? Or is it because of something else? Is there anything we can correct it? We have to think about it. So that is also very important. So we have assessed the patient, we have took the vitals, we have reassured the patient, we have talked with the family. Now we are going to see that anything we can do other than this. Is there any correctable measures? I'll show you next. Please show the next slide. These are some of the correctable factors. Sometimes a patient will be having respiratory infection. That can be corrected by giving an antibacterial. Sometimes the patient will be having pleural effusion. That can be corrected by thoracocentesis or tapping. Sometimes it could be ascites. You can do a tapping. Anemia. Anemia can cause breathlessness. That is correctable up to an extent, not in the end. We can give blood transfusion for that patient. Everything is possible. The patient with heart failures, can we try diuretics and see whether he's improving? Sometimes he will improve. So always rule out all these things. Is it because of this? Is there any way we can we can correct it? At the end, we are finding that there is no correctable factors. If there is correctable factors, definitely go for it. Okay. Next slide. Now, so just a few slides back, and slide back. So first, we have checked for the correctable measures. Next is the non-pharmacological measures. That this is not practiced everywhere. Non-pharmacological methods. This is very important for you all to know also. This is very helpful. As sisters, as nurses, you can try these things. You can tell them. Sometimes a patient having breathlessness will improve a lot with this. Sometimes not. So always check for the correctables. We can try for non-pharmacological methods. What are non-pharmacological methods? Without giving any medicines, we'll try for some hacks. That's what we call. We'll ask them to try because several studies have showed that non-pharmacological slide. Next slide. Next slide. So these are the non-pharmacological methods we usually try here. So studies have mentioned that this will help. For so many patients, it has helped. For some, definitely not. But there is no problem in trying these methods also. So the first point we have already discussed. The calm presence of healthcare team conveying empathy will relieve anxiety. That is the first thing, and that is the best thing, I would say. The rest all are secondary. Okay. Second thing is loosening the patient's clothes. Psychologically, we are trying to relieve all kinds of distress to the patient. We loosen the cloth. Next is using a table fan. It gives air circulation. Handheld fans are available. Small handheld hands. They are very economical also. So we give them and we'll ask them to the caregiver to show that to their face. If it is not available, switch on the fan so that it will be directing the face. And sometimes it will help. They'll feel like there is some there is some space. Keep the rooms, windows open, increasing the perception of space. These all are psychological things. Next is the comfortable positioning of the patient, as you have already mentioned. I thought of it discussing it here. So, position the patient. Most of them will not be knowing that raising their head and part will improve them. Patients with ascites who are lying down, their very big belly or abdomen will pushes the diaphragm. But once the position is changed to like a 45 to 60-degree, it will not push. It comes down. It relieves them. It helps. So for those patients who doesn't know about it, just do it. When the patient comes to your OP, you can try this. You can ask them to, you can lift the bed a little up and keep the position in a 45 to 60-degree angle. And the last one is modified breathing technique like open mouth breathing or pursed lip breathing. You can ask them to slowly breathe through the mouth. But we have not found it very helpful, but we can try. Okay. Now we have tried all these things. We have tried non-pharmacological management. We are going to inform the doctor. Doctor, we have assessed the patient. We have checked everything. We have tried to calm them down. We have tried all the non-pharmacological managements, but still the patient is not settling. We'll go to the medication part. Next slide. So we auscultated the patient. We found it as a wheeze. We can give bronchodilators. in an acute setup, with or without oxygen. Bronchodilators, which we usually we use salbutamol. Short-acting bronchodilators, like otherwise we'll use nebulizations with Budicort and salbutamol, which gives an instant release or a very mild relief for them. It is very helpful to give a. You can try and see sometimes. For some patients, it will not be helpful, but we can try. Give one bronchodilator, like one time, start dose with salbutamol in combination with a small steroid, weak steroid. We can give Budicort and salbutamol. If it is not helping, just stop it. Sometimes the patient will tell that I have good relief with it. That will help. Next two drugs I'll be discussing are two wonder drugs in breathlessness. The next one is corticosteroid. Wait. Corticosteroids are very helpful, not only in the management of respiratory symptoms, but also in other cancers. Because, as you all know, all the cancers, most of the cancers, they cause a peritumor edema. Peritumor edema means around the tumor there will be a edema. So this corticosteroid, what they'll do is they reduces the edema. Even if it is in intestine, even if it is in liver, wherever it is, in the alimentary canal, wherever it is, they decreases all these corticosteroids, helping decreasing the edema. So the pressure exerted near that tumor area will reduce. Patient will have relief. So that is same in the case of a lung. A patient having a big mass in the right bronchus obstructing the airway, and you give corticosteroid, and the peritumor edema decreases. And if the airway opens even by 1 millimeter, it will help. It will be a great relief for the patient. So do not forget about the corticosteroid. And what is the dose of corticosteroids we usually give? What we usually give here is dexamethasone. We usually give little higher dose, 12, 16. We give it as OD dose, and usually in the morning. Why? Corticosteroids sometimes causes insomnia. So it is not given in the evening hours. Mostly we'll try to give in the morning hours only. You can give corticosteroid for few days and then slowly taper it down. Patient will have good relief. Now, we have tried bronchodilators, we have tried corticosteroid. A patient is not improving, patient is still having breathlessness. What will you do? Next. Here comes our wonder drug, morphine. Morphine is not only used for pain. How does morphine helps in the respiratory system? How does it help in breathlessness? How is it possible? Have you read in pharmacology that morphine causes respiratory apnea? How can it be used here? The thing is, we usually use a very low dose of morphine. It acts on the respiratory system and it decreases the respiratory rate. That will help, no? That will help in decreasing the respiratory rate and the sensation of breathing. That's how it's helped. This is very important. You should know how morphine helps here. A patient, we have tried many things. He's having breathlessness. We have tried all other methods, but it's failing. There is no improvement. Patient is still having breathlessness. Go for morphine. How does morphine help? In very lower doses. Morphine helps in reducing the respiratory rate. And it also reduces the inappropriate and excessive respiratory drive. So the lesser the respiratory rate and lesser the sensation of breathing, easier will be the breathing. Patient will be having good relief. So this is very important. You should be knowing how morphine helps. Morphine reduces the inappropriate and excessive respiratory drive, and it is also made more efficient and sensation of breathlessness is reduced. Now, how much is the dose? Usually, morphine for pain, we start with the 5 milligram dose, right? 5 milligram to like 5 milligram Q6 hourly or 5 milligram fourth hourly. We start like that. But for respiration, like for breathlessness, we usually start with a lower dose, like 2.5 mg. That is a very low dose. But we give it in a cyclic pattern. We give it at regular intervals. We can start it as BD. You can give it in the morning and night. You can give it as TDS 3 times a day. You can give it as 6 hourly. If the patient is not improving, like in pain, we increase the dose of morphine, right? If the patient is not having pain relief with 5 mg morphine, we increase the dose. Same is done here. If the patient is not having relief with 2.5 mg of morphine, like a breathlessness, you increase the dose. So morphine is a wonder drug. We use it in breathlessness. You should be knowing about this point. This is very important. How does it act? And what is the how it is decreasing this thing? And you should definitely know the dose. What dose it is given. Very, 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 very important. Okay. Okay. Next. Now, as we said, two things. This is very important. Your oxygen. So, in a usual setting, like we said, we check the pulse oximeter. We see that the saturation is very low, and we start giving oxygen. But here, we find that patient is not benefiting anything from oxygen. What will you tell? Can you directly tell, no, no, we are not going to give oxygen here. This is palliative care. Nothing like that. You will get beaten up. You have to properly communicate with the family. I'll tell you how. You should clearly tell if you understood that the patient is having a correctable cause, if the patient is like treatable, that the case is different. But if the oxygen is not going to help, I'm explaining that situation. How to tell them? You can tell them that okay, you have to explain why this happened, because maybe the big tumor is like obstructing the major airway, and there is no way that the oxygen can be utilized. But we'll try. We will try oxygen for 10 minutes. And if it is not helping, you should remove it. We'll plan to remove it. We start giving a patient oxygen, and it will take only 7 minutes for an equilibrium to achieve. Like we give the utilized oxygen and blood level of oxygen, it takes only nearly 7 minutes. Sometimes a patient from 80, it will be 85. So look for 10 minutes. You can give oxygen for 10 minutes. See if the patient is benefiting, not the increase in saturation. Saturation, even if it is becoming 85, the patient, if he is feeling breathless, is it useful? Do you know the problems of keeping a face mask without any use? He'll be feeling a heat. After sometimes you keep a mask like this, and after it is not give you any relief, after some time there will be lot of heat under the mask. It will cause greater suffocation for the patient. Next is dry gases. We are giving dry gases for the oxygen as oxygen. It will dry up the respiratory tract. It will increase the discomfort. You are keeping a barrier at the mouth. Already you are weak. You are not able to speak. You are not able to speak, communicate with your family. In addition to that, they are giving a mask. You keep like this. Nothing will be heard. You cannot communicate anything with the family. So all these things, try to address. Try to make them understand. There will be families who will not accept this fact. Even for our medical professionals, those who have doctors and nurses in the family, for those patients, they will not agree if they are not knowing the fact. So you should be knowing about this. This is called as a trial of oxygen. Okay. So when this is very important, prior explanation. Just look at the slide. Prior explanation to the family is required to avoid misunderstanding when oxygen therapy is discontinued. That is a very great concern. Sometimes fights can even happen. This doctor didn't give oxygen. This hospital didn't give oxygen. Or sometimes some patients will be admitted for a long time in some ICUs, fearing that they will not oxygen if they go out. So you have to always keep this in mind. If the patient is benefiting from oxygen, if the patient is having good relief, you can go for nasal cannula. That is acceptable. It might also cause a discomfort, but much better than the face mask. Now, for relieving the anxiety, you can give benzodiazepines like midazolam, which is fast acting, and lorazepam is slow acting. But never they are a first line agent. A patient coming with breathlessness, you see that the patient is panic, the patient is anxious. We'll give one midazolam. You should not do that. Okay. Next. So next, coming to a very short topic, cough. Cough, it could be mostly associated with this thing, COPD, and same causes of breathlessness. Most patients having this thing will be having cough also. Just next. അടുത്ത slide. Next slide. അല്ലല്ല next. Next, the back. So most commonly, tumors are likely to cause cough. With the involvement in the airway, along with breathlessness, they'll cause cough also. Next. Aspiration. It could be because of aspiration. Cancer, involvement of pleura, pericardium, and mediastinum can also cause. These are the different causes of cough. No need to focus much on this. Next. So the problems with cough. Next. Okay. The problems with cough are a patient having a chronic cough will be having a chest wall pain. Sometimes a patient complains of pain and could be because of a chronic cough. Fracture of the rib due to cough. Severe coughing in a frail patient can cause fracture of ribs. Cause urinary incontinence. Continuous coughing. Sometimes the patient will get urinary incontinence. They will not get a control when they have a severe stress and pressure is exerted on the bladder, and they will have incontinence. Sweating, exhaustion, disturbance of sleep. Sleep at night is disturbed sometime due to cough. Okay. Assessment is same, like we have to take the physical examination, take the history. Next. Management. About the management, it is same. Like just look for any correctable factors. Sometimes all these tumors causing pressure in the lung causing cough. If we give a radiotherapy for such cases, it will benefit. Now, like the same, nothing is benefiting. There is no correctable measures. There are everything have tried. Tumors, steroids we have given, chemotherapy we have tried. Still the patient is having cough. There is no relief. Then here comes our wonder drug. Here also. Next slide. Next slide. We give centrally acting antitussives like morphine in low doses. Same thing, opioids, we'll try opioids for cough also. It acts as a cough suppressant. It acts centrally and decreases the cough. Okay, next slide. And if it is a dry cough, I'm telling about dry cough. If it is a productive cough, we can try for other rotasives like mucolytics, ambroxol, bromhexine. All these can be also tried. Demulcents like soothing substance like glycerol can be added. We can prescribe cough syrups in having all these contents. Okay. So that's all about cough. Cough is nearly like the causes and this thing are different, but the management, if you're trying like and nothing is like there is no treatment, we can go for morphine for that also. Now, in short, I'm just made a scenario and we can discuss all our points. So we are coming to the end of our class. And this is a scenario what I told. A 65-year-old male patient coming to your casualty with complaints of severe breathlessness, not able to speak, not even looking at you. His extremities were cold. Reports showed that he had a CA lung, malignant lung mass with a mass obstructing the right main bronchus. SpO2 is 87, BP is high, respiratory rate is 24, pulse rate is 100 per minute. He was accompanied by his wife and relative. So, how do you go for it? We see the patient. First, we try to address him. We talk with him. We reassure him. We'll discuss with the family about the investigations, whether to further proceedings, about what we are going to do. We'll the other thing, SpO2 is there. We check all the vitals, and we have to tell the caregivers also about this saturation thing. Otherwise, everybody will be looking into that only. Everybody will keep on coming on checking. Oh, saturation has increased. Oh, saturation has decreased. Saturation, like that, they will go beyond that, behind that. So that should be also kept in mind. Then look for all your vitals, examine him. We start him on bronchodilators. We try to first we'll see whether there is any correctable factors. Then we'll start with our we try giving nebulization. We also try a non-pharmacological methods like keeping a fan, loosening the shirt, upright position of the patient. This is very important. Okay, the non-pharmacological techniques are very important. Then what making the patient lie a little up. Then we start the nebulization. We give steroids. It is not working. We go for morphine. Even if it is the patient's anxiety is not coming down, we give a midazolam, like that. One more thing, after doing all these things, will you shift him to an ICU? Usually, what we do is in a usual common setting, a patient coming like this with severe breathlessness, after doing all the initial things, we'll tell them that this patient is very sick. He has to be kept in ICU. You need that. He has to leave his family there. It will be his last days of life. He want want the presence of his family also. So that is important. Allow him to be with his family. If it is required, you can shift him to an ICU. Otherwise, let him be with his family. Let him enjoy the last days of his life with his family. So make sure about it also. Next slide. So that is what realistic reassurance. Don't give false hope. This is what we use, the common sentence we use here. Like, one of us is going to be with you until you're feeling okay. Then about the presence of family and discuss with them regarding shifting him to IC or what. Talk with the family and all the non-pharmacological technique also. Thank you. That's all about respiratory symptoms.
Thank you, Dr. Nayana, for that wonderful presentation. I think we have in 5 minutes, we can take any questions you want to ask Dr. Nayana. You can unmute from your end and speak, or you can give your question in the chat.
If you have any doubts, please ask. Because the usual setting we see in casualty is not the thing we practice here in palliative care. So you will have a lot of doubts. Any questions?
Doctor, sometimes the patient's relatives wish us to send the patient to ICU for more care. At that time, what we can do?
Okay.
At that time, we are wondering about the patient's life. Patient is telling that I am not like to go to ICU and I don't need to go, that I want to die. But some relatives, the daughters and sons, they wish to send the mother to or father to ICU. At that time we are in a critical situation.
Yeah, okay. I can totally understand that usually happens here. But that is where your power is as a palliative care nurse. You have to definitely communicate with the caregiver. That the communication, everything lies in the communication. You have to clearly explain them that if it is benefiting, okay, we can take shift him. But
Yeah.
if it is not benefiting him, most of the people will be panic at this time. They won't be thinking about all these things. They will only think about like how to save their loved ones. If you are taking to ICU, they will take care of. They will never think about that this patients want to be with them. They want to communicate. They won't be thinking like there are exceptions. Some even after communication, they will not accept all these concepts. In that situation, we have to compromise, but we have to try our best. We have to communicate them very properly. We have to take time, talk with them. Maybe we have to talk with them multiple times. Just tell the wishes of the patient that if that may be the last wish, that may be his last wish. We have come across many situations like that. Like in our day-to-day life, it is little difficult to convince them that this is the like there is no need because they are leaving them to death. That is a very great decision that lies upon your power, ma'am.
Thank you.
Okay. Proper communication. That is very important here.
Okay. Thank you.
Any other questions to Dr. Nayana? I guess no. So I think we can move on with our case presentation. And if you have any questions, please do put it in the chat. We will have it after the case.
Good evening, everyone. Good evening, Doctor.
Good evening.
Good evening.
Good evening.
Okay, I'm Vitneshwari Ganesan from Palliative Care Sunway Medical Center. I'm a staff nurse doctor from Malaysia.
Okay.
And today I'm presenting a case on my patient. Patient is a female and 68 years old, diagnosed lung cancer stage 4, metastasis to pericardial effusion and brain, bones, and adrenal. Diagnosed in November 2022. Okay, presenting complaints. Patient had shortness of breath, cough several weeks. Patient febrile, temperature 38.6, had pericardial effusion, constipated, slightly insomnia, and patient also had DVT and tremors on hand. So history of illness for this patient. This patient diagnosed stage 4 lung cancer, metastatic to brain, bones, and adrenals, diagnosed in 2022, able to ambulate with assistance. Patient also had a pericardial effusion, drained 500 ml of straw-colored fluid. Initially, patient admitted for respiratory as planned earlier by primary oncology. And patient also successfully completed 4 cycles of RT and awaited for gamma knife treatment. So that's the reason patient was admitted. So during upon admission, patient appear good actually. Definitely clinically is not so good, but appearance was like patient is like stable, like healthy, but clinically it is not. Totally is the opposite. Next. So upon examination, this is doctor's examination. Lungs are scattered. You can see in the picture. Abdo are soft and tender. Neurological assessment, upper limb 5/5, lower limb 5/5. Cranial nerve is intact. And functional status are ECOG 1. Vital signs are stable, 110/72 mm Hg and SpO2 95, heart rate 71. On oxygen, 3 liter via nasal from. And blood test taken on WBC, HB, natrium, urea, creatinine, glucose. And the TB, ASTL, ALTL, CA are normal for this patient. Next. Okay, treatment and significant investigation done for this patient is awaiting gamma knife to start, expect over 6 weeks actually. So patient had radiation therapy total 4 cycles to spine T3 to T5 and pelvis, and CT thorax pericardial effusion shows, and PET CT left upper lobe lung mass noted 5.8 times 5.5 times 8.2 cm involved, mediastinal pleural, multiple nodes, bone skull at T4 to L3 S2, right ilium with soft tissue brain. You can see the picture has given below. That is belongs to patient actually, not the Google picture actually here. So MRI shows about multiple brain mets, some necrotic hemorrhagic, and also pending NGS, which is next generation sequence lah. This test was pending actually. Psychosocial aspect, this patient married with 3 children. Patient has 3 children. Elder son is 40 years old, but passed away for some time. And daughter is 39 years old, by staying in Germany away with the patient. And younger son is 37. So unfortunately, 3 of the children also married and away from the parents actually. So only the patient and patient husband staying together with the Indonesian carer. And patient own a hardware business in town, and patient husband working together to look after their own business, and as purchase and come to long end of life care. Patient also has purchased Nirvana package here called ashes, which is Nirvana package meaning ashes placement post cremation. So also they have bought, and will writing was in process, and fairly asymptomatic presently, but expressed wish to minimize any prolonged suffering in future, and mentioned not afraid of death. So at the same time, patient has worried about current health condition also, and has a little hope for further treatment still to prolong. Next. And medications are served such as IV Dexa, IV Nexium, Tab Bisoprolol, Stat Denosumab, Subcut Morphine 3 mg, Subcut Mida, nebulizer, IV Furosemide, Subcut Clexane, Senocort, based on the patient's sign and symptom over here, as mentioned earlier lah. Tab, azithromycin, continue other medications, furosemide, amiodarone, and on CS, a patient also on CSI morphine 20 mg, normal saline to dilute with 22 mils of normal saline, make it up to 24 mils and start at 1 mils per hour initially first started. Secondly, that was at ICU actually, and secondly, based on patient's condition deteriorated, CSI morphine increased to 70 mg plus midazolam 30 mg, added Buscopan 60 mg, add with normal saline 8 mils, make up to 24 mils, run at 1 mils, and this was patient at ward post extubation, from admitted in the transfer from the ICU to ward back actually. So main concern for this patient before when she was intubated was unsettling cough, breathless, pain, insomnia for several days, and also need assistance for daily activity living, immobility due to the DVT, and patient appear with low mood. So for this, we also arrange psychologist for psychosocial support actually. And summary, so this patient was desaturated from the ward, and SpO2 dropped to 89 before gamma knife, and transferred to ICU for close monitoring. So noted patient started EF in the evening with a heart rate of 150 to 170 BP, beat per minute, and BP at 110 to 140 mmHg. So IV amiodarone 300 mg over 2 hours started. ECG shows AF and ABG type 1 respiratory failure. So did patient deteriorate further till patient need intubation and extubated in 3 days after discussed with family as patient previously wished to pass away naturally without pain. So upon extubated, patient lasted for 2 days in the ward and passed away peacefully surrounded by family members. So family expressed her passing was peaceful without prolonged suffering and thanked palliative care team for the output. So my question is how to control patient sign and symptom of respiratory syndrome and how to help patient with nocturnal cough. And also, does mindfulness breathing therapy help for the above patient during ICU stay in this case?
Thank you, sister, for that case presentation. I just want to ask participants if there is any questions to be asked regarding the patient story to the sister. Any questions regarding the patient story? No, I guess.
Well, that was a very nice presentation. I think it's Vigneshwari, right?
Yes,
Vigneshwari.
doctor.
Yes. That's a very nice presentation. Everything what I have mentioned as is there in this case. Patient was breathless. He had AF. He was sent to ICU, and later he was intubated. There is so much emotional concerns, in ventilating in such patients, ventilating, and then intubating, extubating that patient. He has to undergo. I don't know. His mental state will be so this thing. Okay, anyway, he was taken out of the ICU by his family members. He was on pain medication that might have helped his breathing difficulty also. So about the controlling the patient's signs and symptoms, as we have discussed everything, like giving corticosteroids, everything like that, that we have already mentioned. But I would like to talk about the nocturnal cough. You have asked me that how to help the patient with nocturnal cough. First, we have to, there are a lot of causes for nocturnal cough. So we have to find out what is the problem with him. Because most of the time it will be a correctable cause like GERD, gastritis, like gastritis. GERD will cause nocturnal cough because when the patient lies down, the sphincter loosens and the acid reflex comes up, and the patient may have nocturnal cough. Most of the people, it will be like that. Otherwise, it could be like a post nasal drip. Sometimes patients having tumor, they'll be having a post nasal drip backside of this thing, and it will irritate the trachea, and the patient will have cough. So it is not like how to treat this. We have to find the cause of like the problem in that patient, and we have to treat accordingly. So most of the time it will be GERD, and other if it is in the other case, we have to find the cause and try to solve it like that. If it is not helping with the other medications, and if it is a dry cough, disturbing the sleep, and if it is causing so much distress to the patient, we can go for morphine also. And next question is does mindfulness breathing therapy help for the above patient during ICU stay? Okay, I have read an article about which has been mentioned in the American Thoracic Society. In that, it is mentioned that it is recommended for those patients who are having chronic cough, those with cancer patients and all. We can try. Of course, we can try. There is nothing like you can't do that. You can try. It is a breathing practice. Is it? Is it practiced routinely in Malaysia? Is it like that?
Sorry, repeat again, doctor.
Like breathing practices, no? As you have mentioned in the third point, breathing pattern, that breathing therapy, mindfulness breathing practices.
Yes, we do practice, doctor.
Okay.
We have some postings, printings on these. So usually we identify patient problem and we provide the printed um, uh, printed guideline. We do have some special printed guideline for that. So we provide with the patient and sit together with the patient, try to teach them and try ask them to re-demo back, and then always often check with them time to time during the rounds. Is that working for them or not, helpful or not? So sometimes patient did mention that it's helpful for them actually. Sometimes patient couldn't make it, so that depends on the patient situation also, that actually.
Okay. We can consider it as a non-pharmacological method, is it? This is
True,
definitely,
doctor, exactly, yes, I do agree that there is a non-pharmacological
yeah,
method actually.
very good. That usually we don't practice it here. We look into it. Okay. We can, I would say that we can try this if it is benefiting for the patient. If it is benefiting the patient, it can be recommended. But sometimes when the patient is having a severe breathlessness and cancer breathlessness associated with cancer is like initially it will be very mild. At the end, it will be like very severe. In such a case, asking the patient sometimes to do like this may not be possible. Most of the people will not be conscious. They'll be just breathing like that. So for other patients, we can definitely try, I would say.
Maybe beginning of the stage, like
Yeah,
maybe patient is anxious, I
yeah,
think will be more helpful rather than like a patient is too ill. I don't think so they able to concentrate on what we are talking actually, doctor.
yeah. Maybe all this will help to reduce their anxiety also. Anxiety is also a very important factor. When we'll understand that only after like talking with the patient that they had so much stress. They'll be in panic only. They'll be stressed, panic like that. So it will help in reducing the anxiety also. Like that. That I have mentioned. That's as I mentioned that cycle. It will helpful like that. Okay, thank you. All the signs and symptoms I have discussed already, so I'm
Thank
not
you,
going to.
doctor.
You have any other doubts? Because I'm sure that most of the things I have spoken here will be very new to you all. Nobody will say that there is no need to use a pulse oximeter, and it will be new for you, like shifting a patient from ICU and like leaving them to die peacefully. So if there is any questions, I can help. The communication part is also very important. That is a very great concern. Like sometimes there fights can happen, like problems. Mm, that is also that. So that is very important. Communication is much more important than this thing.
Any questions to ma'am?
Hope everyone has understood the session, at least like few points.
Very clear, doctor. Actually, your slides are very informative actually.
Thank you.
Clearly, we
you,
got the
doctor.
points.
Sorry.
Clearly, we got the points. Thank you.
Okay.
Yes, actually.
Thank you so much.
Okay, thank you, ma'am.
I think we can wind up for today. Thank you, ma'am, for that wonderful session.